Everyone, can you hear me well? Is my mic on?
Yes.
Okay, great. I'm Mia Keeys. I serve as the Health Policy Advisor for Congresswoman Robin Kelly. She's the chair of the Congressional Black Caucus Health Braintrust, and I also serve as the Policy Director for the CBC Health Braintrust. And on behalf of the Braintrust, and certainly by extension on behalf of National Minority Equality Forum, our partners here in the summit, thank you so very much for your continued attention during this summit, and especially as you focus your attention on the conversation, the very rich conversation that we are going to have now on maternal wellness. So before we get started, let me go ahead and introduce our very lovely panel. I couldn't think of anybody even more passionate and just knowledgeable about the topics that we're going to discuss today than our panelists here. So I'm going to start to my right. To my right, we have Lisa Asare, if we can just welcome her. She's from New Jersey. So Lisa serves as the Assistant Commissioner of the Division of Family Health Services at the Department of Health in New Jersey, where she handles myriad portfolios, including child health, maternal wellness, and all the lovely things that she'll talk to us about today. Being a Philly girl, I'm really excited to see a proximate neighbor.
Yay.
Exactly.
I'm happy to see you as well.
Indeed, yes. Also to my right, we have Dr. Joia Crear-Perry. We can welcome Joia. Joia is the founder and director of the National Birth Equity Collaborative, and which is always a fun thing to say.
Yes.
Yes, I walk myself through it every time.
Exactly. It's a tongue twister.
It's a tongue twister indeed. And so Joia's work is really quite, she's an OBGYN by training, and her work, both in the clinical world and non-clinically, she roots her work in the idea of racism, not even the idea, but really the fact of racism really contributing, unfortunately, to distresses and disease, and more namely to maternal wellness. And we'll talk more about that today. And some of our panelists in previous panels mentioned that, so she'll help to unpack that with us today. So thank you, Joia, for being here.
Thank you.
Indeed. Right, to my immediate left, we have Dr. Etiebet. What a lovely name, by the way, that I really had practiced saying, and I love it. It flows quite well. Dr. Etiebet joins us here from Merck for Mothers, where she is the lead and executive director of Merck's overall $500 million global initiative to bring women into wellness and to create a world in which no woman would ever die from giving life. And so we are really quite excited to hear more about what Merck is doing, both in the private space and how they're partnering across the world with, what is it, over 100 countries and
100 partners
in 40 countries. Yeah, so you'll be able to walk us through that and help us think globally about this very home issue. Yes. And then finally, last but not least, one of my favorite people that we've worked with consistently in Robin Kelly's office on the issue of maternal mortality, we have Elizabeth Dawes. Let's give it up for Elizabeth. So Elizabeth is the co-director of Black Mamas Matter Alliance. She has super cool bags that we have. So if you see the super cool bag, ask her more and more questions about Black Mamas Matter Alliance and what they're doing in terms of a national agenda to bring women into wellness, not just from a maternal standpoint, but from a reproductive justice and overall health standpoint. So ladies and gentlemen, I hope that you're really ready to engage in a rich discussion. Feel free to ask questions later on, either during the question and answer panel or even talk to our panelists after that. I want to do some audience engagement before we jump into the main discussion. So does everyone have a pen or something to write with, crayon, color pencil, something? Take that out on your notepads. And we're going to do a bit of word association. Even the panelists are going to do this. If you don't have a pen and paper, you can do what Joy is doing and use your phone. Because she's so millennial. She's a fake millennial. Right. All right, so I'm going to say some words, and without thinking too much about it, I want you to write down what immediately comes to your mind. Okay? Ready? All right, here we go. Mother. Black mother. Pregnancy. Data. Baby. Medicaid expansion. Father. Postpartum. family, policy, stress, opioid, racism. Okay. So during our discussion, feel free to go within ourselves, because sometimes our minds wander, right? That's real, even during conversations. Feel free to think more and more about those words. And again, when you talk to panelists later, feel free to engage them on that. Panelists, while you're answering, feel free to share your answers to the word association as well. But of course, no pressure. All right, are we ready to get started? Yeah. All right, so Lisa, if you can just tell us more about what you're doing, who you are, and the work of New Jersey in terms of maternal wellness.
Happy to do that. So hello, everybody. And thank you for having me. This is really an honor. I feel like I'm on a panel with my own sheroes, so yes. I'm just thrilled to be here. But why am I really here? I'm from New Jersey. I am the Assistant Commissioner of a division called the Division of Family Health Services. We manage MCH programs, the WIC program, and special child health. But I think I am here because the data is not really good in New Jersey. We have terrible infant mortality rates, really discouraging and troubling maternal mortality rates, and what the issue is really is the disparity and the data. So what are we doing? I'm staying up at night about this issue because it's something that impacts me personally. I'm also a mother of 3 children, 22, 19, and God gave me a bonus. I have a 10-year-old daughter as well. And she didn't cooperate this morning, but that's a different conversation. But I say that to say that we have a few things in New Jersey that are working in our favor. We have a champion in our First Lady and our governor. We have legislation that is really pushing us in the right direction. We just had a 14-bill package that was put forth, all bills dealing with maternal health. Things like the reimbursement of doulas, things like developing a perinatal community health worker curriculum, things like Medicaid expansion, pilots around home visiting. And we also have a commissioner that's very dedicated that has allowed me to put $4.3 million towards addressing infant mortality and maternal mortality, and particularly the disparities. I say that because it takes a different approach than what we had been doing I've actually been with the agency for 20 years. I came when my daughter was 2 and said I was there for a minute, and she's 22. It is really an opportunity to really direct and really guide our efforts. We are focusing on things that we know make a difference in communities of color, like social supports. We have initiatives around group prenatal care, and I'm most proud of the work we're doing with our doulas. We have created a workforce of community-based doulas, and what is really beautiful about that is just a month ago it was announced that the state was committing $1 million towards doulas. So $1 million in the state of New Jersey towards doulas, and we hope to do it right. I say that because sometimes we put money forth for programs and we don't get the return and we don't get the uptake because we really don't give people a meaningful wage. So we are working on that issue to make sure that our doulas are compensated, are trained, their capacity is built, and so on and so forth. So as much as I sort of started with the bad news about the stats, I am really encouraged because I think New Jersey is primed to be a leader in this space if we can get it right. We've learned from many of our colleagues. I said the sheroes are here because I learn from them every day. But I'm determined in my time in this spot to really make a difference for these communities because it's just been too long. And it's really unacceptable that we are still where we are. But I'm encouraged. So thank you for having me.
Thank you. And we'll hear more about that as we open the conversation. Joia, how about you? If you can just tell us about the work that you're doing and all of that.
Yeah, thank you so much. So I do not have the clicker. I did give one slide. I don't know if it'll happen, but oh, good, here we are. So good morning, everybody. Still morning, right? So honored to be here. Thank you, Mia, for inviting me. And I love the Congresswoman. In fact, I've been coming to this as long as I can remember. So some of you, I feel like this is family and this is home. And it's great to be on the stage and share my work with you all. As was mentioned, I really get to work on both Black maternal and infant health across the country with large organizations such as the National March of Dimes and others. And also I'm on the advisory committee for the Black Mamas Matter Alliance and working in city and states. And the core function of our work is really to ensure that people understand that the reason that we have inequities in birth outcomes is not because people are broken, right? Black people are not genetically different. There was no, God didn't put us on different continents so we wouldn't mix, right? That those were all made up untruths. And that really the reason that we have inequities is because of policies and because of the undervaluing of people over generations. So the goal of our work is really to say, since we made those policies to create harm with the belief of a hierarchy of human value based upon skin color, we have a tremendous opportunity to end that. So now we know that's wrong, and what are we going to do differently? So this is kind of the framing for our work. We work really hard around the social determinants, and you will see this is really exciting when we think about social determinants, things like safe and affordable housing, right? She mentioned the importance, there are a lot of folks earlier were talking about the importance of health care and hospitals and Medicaid investing in social determinants. If you could push it again. Because those things cause unhealthy behaviors and psychosocial stress. So it's exciting for us not to blame individuals in their choices. And I was in New Orleans after Katrina. The World Health Organization would come in and talk about this idea of social determinants. It was exciting, right? Like, it's not just problematizing individuals and coming up with programs of blaming individuals, but how we can look at all these things that impact your health. Push it again for me. And those things cause a disparity in disease and well-being. So this has been a great 15-year run of really understanding social determinants. But you see the top of my page is empty, right? This is the basis of my work. Because really, although we've gotten to this idea that zip codes matter, which is exciting, and that social determinants matter, which is exciting, until we push the button one more time, or a couple more times, and look at what's above the social determinants. How did we get here? Black folks didn't just decide to live next to each other because we like other people of color, right? Push it again. We have a power and wealth imbalance, okay, again. And those are things like our labor markets, our housing policy, our education system, globalization, our social safety net, social networks, and tax policy. So we have to unpack all those things because we're just going to keep making programs around transportation and housing. Push it again. And those have three main root causes in the US context, again, which are racism, classism, and gender oppression. Now in the global context, you might want to add things like religious fundamentalism, or you might add tribalism, or you might add, I don't know, there's a bunch of them, right? So, but whatever the basic core inequity that causes this power and wealth imbalance, it's important to know that those are your root causes. One more time. So although it's exciting for us in this space, at the National Minority Equality Forum and the Congressional Black Caucus, to really focus on the importance of social determinants of health, until we can honestly have a conversation about racism, classism, and gender oppression, we will still see inequities in maternal and child health.
You broke it down.
Okay.
And we're gonna unpack that even more, especially with respect to maternal wellness. So thank you so much for that, Joia. I'm going to turn it over to Marianne. If you can also just tell us more about yourself and what Merck is doing and your vision.
So thank you so much, Mia, and I'm so excited to be here with you today and speak on behalf of the whole Merck for Mothers team and our whole Merck for Mothers and Merck family. I don't know how many of you know, but back in 2011, our CEO, Ken Frazier, made a $500 million commitment to end preventable maternal deaths worldwide. And when he did that, we didn't really understand what was happening in maternal health in the US here, but the team asked a lot of questions. And what they found out was that there weren't really the answers in the US. Folks knew that something was happening, but because there was not the data, we did not really know the extent, nor did we know how to solve for it. And I want to bring that back to some of the things that Joia said earlier. When you look around the world as a whole has actually been able to reduce maternal mortality by about 44% in the last 25 years. But here in the US, we haven't. Those numbers have gone up, and we've seen that the disparities in maternal health outcomes, those have actually widened. And when Joia talked about her slide about the confluence of race and gender, as well as the confluence of race and investments in our communities, I want to share two different stats with you that shocked me as I've been doing this work. So the first We know that nationwide, Black women are 3 to 4 times more likely to die during childbirth and pregnancy. Can you give a guess, or if you are, I'm sure this is the folks, this is the audience who knows this information, but Black women are only about 23 times more likely to die from cardiovascular disease, and 23% higher deaths, thank you, 23% higher deaths from cardiovascular disease, and 189% higher deaths rate from diabetes. But the percentage increase from maternal mortality, it's 243. So there you have that confluence of gender and race actually increasing the worst outcomes and increasing the disparities we see in maternal health. When you look at our hospitals, we know that Black births, the majority of Black births, 75% of them, happen in hospitals that are either high Black birth hospitals or medium birth hospitals. So these are hospitals that are giving birth to the majority of our Black babies. We know that those hospitals, for any woman who goes into those hospitals, they're at an increased risk of dying. But we know that Black women who receive care in those hospitals have an even higher risk of dying. So again, we're looking at that confluence between race and investments in quality care in our health systems. Mia wanted me to talk a little bit about the similarities or the differences that we're seeing globally versus what we're seeing here nationally. And one of the things that continues to just keep hold of how I think about this issue is maternal mortality is not just a vital sign of our health system. It's a vital sign of our society. So where we see fractures in society, whether they're from war, whether they're from religion, religious oppression, cultural oppression, racism, that's where we see our Black moms dying. And that's where we have to do something about it. So I look forward to the questions and talking about more about what Merck for Mothers is doing, but let's have...
Yeah, that's quite a nice segue. And we're going to open that up for certain. Thank you so very much, especially because we don't, we don't always think about the global aspect of health, and we really have to do a lot better about that, even from a policy perspective. So let's make certain to challenge ourselves continuously. Elizabeth, tell us a bit more about what you're doing and what you have done and moving forward.
Thank you. Good morning, everyone, and thank you, Mia, for inviting me to participate. And I also want to thank Congresswoman Kelly for her work with the Congressional Black Caucus Health Braintrust, with the Congressional Caucus on Black Women and Girls, which is how I first became familiar with her, and also with the MOMMA Act. You know, we need more leaders like the Congresswoman who are making progress on Black maternal health. So I'm with the Black Mamas Matter Alliance, and we're a relatively new initiative that started in late 2015. To work on advancing Black maternal health rights and justice in the United States. We filled a critical gap in a national voice and a national perspective and advocate for Black maternal health, to raise awareness about the disparities that my fellow panelists have already mentioned. We want to create a world where Black women have the rights, respect, and resources to thrive before, during, and after pregnancy. And we do this by seeking to change policy, develop meaningful policy that will implement real solutions that work for our communities by cultivating research, justice-based research in particular, community-based research, and we have a value around having the resources and knowledge within our communities to do that research so that others don't need to research and experiment on us. We also seek to promote holistic, comprehensive, and respectful care among Black women. We know from what the panelists have described and what we've seen in the news that there is a big problem with how Black mamas and Black birthing parents are treated within the healthcare system, right? From the administrative staff to the clinician, the stories that we've heard are horrendous. And if you heard some of them, you'd be really shocked at what women are experiencing trying to bring life into the world. And so we have a big initiative around changing that. And finally, we work to shift culture, and that includes changing the narrative from one of blame and shame to one that exhibits empathy and value for Black women's lives, and is really focused on comprehensive solutions rather than villainizing or demonizing and blaming Black moms for what's happening in our community. So I just wanted to mention that, and I also want to name our motto, which is listen to Black women, trust Black women, and invest in Black women. And for us, this is really a strong frame for how we approach our work, how we do our work. And it's a rallying cry for us in how we organize as well. So it's really important to listen to them, and we found from our work that not only are, providers not listening to their patients, and listening to, Black women in particular, but that society isn't listening to Black women, that the Black women professionals that are doing this work in maternal and child health organizations, in academia, in whatever setting they are in, aren't being valued, aren't given a seat at the table, and when they do speak up, aren't necessarily listened to or appreciated. We also acknowledge the Trust Black Women movement, which was grounded in which was initiated by the reproductive justice movement, and our work is grounded in the reproductive justice and birth justice frameworks. And so Trust Black Women is really about, once you've heard our voice, once we've shared our information and our perspective and our thought leadership, trust us. Trust Black women to know what's working for their communities, what doesn't work. Trust Black women to know what's going on with their bodies. Serena Williams, her story was a great example of not being listened to, but then not being trusted to know what was going on with her. And then finally, invest in Black women. And so this is something that we hold really near and dear. And when people ask, what can we do? This is one of the first things that I point to, which is invest in Black communities, invest in, again, our thought leadership, our knowledge, our expertise, and invest in the organizations that are doing this work on the ground in communities that have that cultural congruence with their communities. Because there are a lot of people who are now trying to take on health equity, but we know our communities best, and so it's important to invest in those initiatives that have an ear to the ground and have a strong relationship with people who can inform their efforts and make them the most impactful. And so that motto actually emerged out of our first Black Maternal Health Week that we held last April. And I'm glad this panel is happening now because we are just about to start the second annual Black Maternal Health Week, April 11th through 17th. And that's a great opportunity to learn more about the issue of Black maternal health, to hear from thought leaders, the kindred partners and collaborators that are part of our network. We've got over 50 folks that will be lifting up their work throughout the week. And it's a great opportunity to engage in the conversation and learn more about how you can contribute and what some of the issues are. Yeah. So thank you. I'm looking forward to questions.
Thank you. I think that was a really awesome segue into making the frame for the conversation. And please, panelists, jump in on this. If you all can help us unpack maternal mortality and maternal morbidity. We do a lot of talking about the death statistics of women, and especially Black women, and you pointed that out, Marianne, that maternal wellness is a sign of the times with respect to the nation's health, and it's exacerbated due to gendered racism. So if you all can help us to unpack maternal mortality and morbidity. Let's jump into that, from a domestic frame as well as from a global frame.
Okay, I wanted to add, I forgot to mention in my intro, but I wanted to add that, as Dr. Etiebet mentioned, that severe maternal morbidity is increasing. And I found some interesting data, and I found a chart from the CDC that was actually a pyramid. And so they started with maternal death at the top, followed by severe maternal morbidity, followed by near misses, followed by near misses after death, like people who would have passed away without an intervention, severe maternal morbidity, which are blood transfusions, hysterectomies, a blood infection. These are things that are on the rise. And I wanted to point out hysterectomy in particular because there's some other data that shows that Black women are more likely to be offered or to be recommended a hysterectomy. And if we think about our history, we know that people of color have been targeted for centuries for eugenics and to control their reproductive capacity. So that's another layer of conversation we could have about how maternal morbidity is affecting Black women if it's leading to increased hysterectomies.
And very briefly with that, the base of hysterectomy, the word comes from the word hysteria. And the idea of a hysterectomy was developed in a time of like you mentioned, extreme experimentation on Black women without use of pain medication. If you all don't yet know about J. Marion Sims, who is considered the father of gynecology, there's an entire statue of him erected in Central Park. Look him up, right? Oh, you took it down.
We took it down.
It's not there anymore. We took it down.
Yes.
Boom. Okay. See, that's it. That's advocacy at its best.
Advocacy works.
Right. But you're right. The entire history of caring for Black women.
And yeah, I'd like to say two things about the severe maternal morbidity, which is that harm, lasting harm, that women can have after a bad outcome or a bad experience during pregnancy and childbirth. And so for every death, we have at least 100 of those cases. What we're finding out now is where we were 20 years ago, where we didn't have the data on deaths. We're actually in that place now where we don't really have the data on morbidity, yeah? So we, especially globally, this is not something that's tracked, but we need to do a better job tracking it, because that's when we can prevent not just the harm, but make sure we prevent the death. The opportunity of investigating these near misses or these harms is that we can actually talk to women.
That's right.
Yeah? And we can find out from them what their experience was that led to that poor outcome. And so, for example, one of our partners, one of the Merck for Mothers partners, is the New York City Department of Health and Mental Hygiene. We've worked with them to expand their mortality review committees so that they include morbidity reviews, and so that women can actually come to the table and share their experiences of what happened. And many of those women, are Black women who previously had not necessarily had their voices heard, but I think even more importantly, had not had their voices integrated into institutional structures that actually make decisions and allocate resources. So I think that's a real opportunity of focusing on maternal morbidity.
And we're going to unpack that even more, the idea of data not just being about the numbers. The anecdotal stories are incredibly important. It's how we build policy. It's how we drive that. And later on, Lisa, or do you want to speak to this now, the data piece?
We've been doing maternal mortality reviews in New Jersey for the last 80 years. So we have really been a pioneer in this work, and we still need to do better. We recently passed legislation that really tightens up our maternal mortality review committee work to really legislate who should be on the committee, to include women like Marianne just described. We also have a new law that came out, a statute last year that was passed that created a maternity care report card that speaks specifically to morbidity. What are those near misses? What's going on with C-sections? Which hospitals are known to provide unnecessary C-sections more than others? We're really trying to get information out to folks so that we can make informed decisions. So we're doing quite a bit of work in New Jersey around maternal mortality, but morbidity as well, because it's the near misses that we also need to work on as well.
Had you wanted to speak a bit to that, Joia?
Yeah, I just wanted to, because I think for people to understand that why the U.S. is going up and everybody else is going down, one of the reasons is we stopped counting. You know how we are, right? So we announced to the world in the late 1990s that we have gotten the best numbers in the world around maternal mortality, and we cured it, and we are done, right? And we stopped counting. And so when we didn't publish official numbers for a while, the global community started holding us accountable. So Black people always need to be a part of the global community. If you learn nothing else we say today, don't ever just count on the U.S. for nothing, okay? So the global community said, I'm being so serious right now. The global community said, hey guys, what's going on? There's actually a commission on the people of African descent, and they came to the U.S. and they said, what's happening? And maternal mortality was the thing that they found the most. And when they, we have not released an official number from the U.S. around maternal mortality since 2007. So when you see all this, we're talking, yes, New Jersey's been counting, but most states have not. And then even in New Jersey, I don't know how, a lot of them have not been robust. So we are now trying to actually count. You'll see the range go from 700 to 900. So even getting to the morbidity, to the mortality, but you don't count, you don't value. So once we declared we had fixed it, everybody else kept going and doing better things, we stopped. Now we're counting and we're all in a panic because the world is watching. The reason I could even speak at the UN in Geneva is because the world is watching and they're wanting to know what are we doing here in the US. And this is a great opportunity for us to then use this, because yes, maternal mortality is the canary in the coal mine, but so is obesity and so is mass incarceration and so is all the other things. So how do we have this conversation around how racism impacts our health using maternal mortality as a global conversation around how we are devaluing people of color and women?
Well, actually, if you can pick up from there, so the idea of race and colorism is a global phenomenon. You can go anywhere in the world. I lived in Asia, and they talked, I lived there for 3 years. We can have conversations about colorism, but the idea of race manifests very uniquely here in the US. So can you talk to us about how race versus racism impacts the body?
So as a medical student, I had a baby early. My son, who's now 22, was born, and I was only about 5.5 months pregnant. He weighed 445 grams, if there are any neonatologists in the room. So I imagine I went through all the risk factors. I was the head of the OB interest group, and so we have all these things, right? Like education status. The only thing that I met was my blackness. So I left medical school in 1997 believing there must be something, right? My professors in medical school said there were 3 races, Mongoloid, Caucasoid, Negroid. So many people who were my age and older believed and were taught that there was something genetically about black folks that made us have babies earlier, that makes us have prostate cancer, that makes us have breast cancer, that makes us have cardiovascular disease. Think of all the data and the research that you see and how that's embedded in how we think and talk. Now, we completed the Human Genome Project in 2003. Our great president came out and said, there is no biological genetic basis for race. So once we let that go, then what's really going on? What happens to our bodies? How does weathering, how does gendered racism, how do the policies and the procedures that we create that criminalize black women in pregnancy, that don't allow for us to take home a baby if we are drug addicted, but expect the opioid addicted mother to take the baby home, right? So those are direct reactions from racism. So we cannot continue to problematize and blame black women and black families for their outcomes without really understanding the structural, interpersonal racism that happens. Yes, people are mean and say bad words to us, but also we have embedded structural racism in this country and in our healthcare system.
Exactly, yes. So to surmise, it's not race, that's the health factor, it's racism.
So if we can take all of that out of all your stuff, I see everybody. Racism, not race.
Yeah.
Okay.
Can I jump in?
Please.
So I wanted to go back to the word association that you that we did. Yeah, that was.
Elizabeth always follows instructions.
So when you said the word mother, I thought love. And then you said the word black mother, and it took me like 2 more seconds, but I thought extraordinary. Because not only I believe that black mamas are extraordinary, I believe we're working to overcome extraordinary challenges. And those are the challenges that Dr. Joia listed on her slide. I've been in different focus groups and things, and hearing stories about how people are going to extraordinary circumstances just to get fresh food, to get food that they would actually feed their families. And that is necessary for pregnancy, right? For a healthy pregnancy, you need nutrients and vitamins and things. They're overcoming extraordinary challenges just to get to the healthcare provider. Transportation was on the slide, and that's something I want to talk about, because people don't often think about these things when we're talking about maternal health. You think about what's happening in the clinical setting, but we're not really focused on what it takes to actually get there, to get care, and then what happens when you are within the setting. So like, for example, in DC, it could easily cost $10 on the metro to get somewhere. And if you think about people living in poverty, $10 back and forth is an excessive amount, and it might take an hour and a half. And so what about your time off of work, trying to access things like prenatal care, or whatever appointment, whatever checkup you need. And so I just wanted to think about not only how black women are extraordinary in our resilience, but that there's a lot working against us, and that's what all of us on this stage are fighting for.
And I think that's a really great segue into just thinking about the overall theme of the summit today, which is diversifying the healthcare professionals across the healthcare continuum, and keeping in mind there are many providers here who are in the audience, academicians, that kind of thing. Lisa, can you help talk us through why we need diversity in the healthcare space and really pull in what both Joia and Elizabeth mentioned?
Absolutely. I think if I can just jump back to the word game, I thought of stress and I thought all the time. What came to me was just all the time, continuous stress. And I think that speaks to Elizabeth's comments about it's more than just what happens in the medical system, right? It's I need childcare, how do I get to work, my partner needs a job, I don't have food, and the list goes on and on and on. So some of the strategies that we've employed in New Jersey is to really put our money where our mouth is and really say that this is about social determinants of health. So as much as I may partner and grant with my traditional partners, I have asked all of my traditional partners to take 20% of the grant funding I'm giving to them and give it to non-traditional partners. So give it to a soup kitchen, give it to a library, give it to a homeless shelter, let them hire a community health worker, let them get involved in the game. Just last week you talked about diversity of the workforce. Just last week I was in a meeting with a sheriff, his lieutenant, a doula, a community health worker, and a pastor. Strange assortment of folks, right? A motley crew. But really necessary to begin to do this work. The sheriff was in Atlantic City and says when he takes his van out dealing with people that have substance abuse and mental health issues, they keep coming across these pregnant women. And he and his squad, they don't know what to do with them. So he calls me up and he says, can you bring me a doula or a community health worker, somebody to get on the van with these people so that when they go out and they see these stressed out pregnant women, they can help them. So what I'm saying really is it's really about a diverse workforce. We cannot do this work the way we've been doing it. We really have to open ourselves up to others, bring in their skill sets, share our skill sets, share the money. Share the money. The money is never going to be enough, but we must share the money and be creative about how we're doing this. We have $4.5 million in New Jersey, and we have been able to leverage $2.8 million additional dollars from our philanthropies. So we have increased our resources. People are coming to us and saying, how can we complement your efforts? What is it that you are trying to do that you cannot do that we can help you with? So I say that to say that we are building doulas, community health workers, building their capacity, training them across the spectrum of issues. Most of my closest compatriots are people that are not from the Department of Health. They're actually from transportation, from labor, from human services, from agriculture, because they have the solutions that my families so desperately need. The last thing I'll say is we did an event last year in February around Black History Month celebrating breastfeeding in the African American community. We thought we'd go in there, see babies at a WIC clinic, see moms, and guess what? What they talked to us was about all of the challenges that they face thinking about going home from the hospital with the baby. I don't have my temporary disability insurance or my family leave insurance. I can't even talk to you about breastfeeding because I need to take care of those things first. So we did a series of trainings for community health workers and home visitors, family resource specialists around temporary disability insurance. These are the things that people need. So we'll get to the breastfeeding, but we got to sort of handle those things on Maslow's hierarchy of needs, those basic human needs first. And so that has been much of the strategy we've used in New Jersey in conjunction with our First Lady, who's a champion. When she calls people to the table, you better believe they come. And they've been coming, so we're proud of that work.
I want to actually bring something up that you mentioned.
Okay.
So we are running a little close to time, but before we close and open up for questions, I wanted to speak to something you said earlier about how what we don't count, we don't value. And Lisa, you mentioned, well, both you and Marianne mentioned the data, right, and the stories and the significance of listening to women. All of you did, actually. So if you and Lisa can help us think about the role of data, of evaluation, of even innovation in this space.
I think that's a great question. I say, it's the stories that pull us in, but it's the data that pushes us to action. And I do think we would not be in this moment of time when there is so much mobilization around this issue. What I want to make sure is that some of the innovations Lisa just talked about, the multi-sectoral, working across different agencies, having a diversity of partners at the table, that stuff doesn't stop when we leave this room or when the headlines change to something else. So how is it that we can ensure that, these things which we believe are working, sustain and get financed, and it's the data that does that. And so, Merck for Mothers has worked with partners to make sure that the programs that we're supporting, we evaluate them, we understand what the best practices are, we work with partners to advocate for those best practices to be spread, and not just the best practices within a country. Where we found actually the most exciting catalytic innovation happening is when there's cross-fertilization and cross-pollination across nations, because really the same issues that are facing mothers in Camden are the same issues that are facing mothers in Nairobi. It may look a little bit different. The solutions obviously have to be customized, but it's coming from that same issue of we need to invest in them and not just their healthcare.
So investment, data, driving data into policy and really being actionable on that. If my boss were here, I have to put in a shameless plug for Ms. Robin Kelly. Yes. Congresswoman Kelly has a bill called the MOMMA Act, MOMMA, and that stands for Maternal and Offspring Mortality and Morbidity Awareness. Okay? Right. Yes, indeed. So you won't forget. It's HR 1897. And when we were writing the bill, it took us a little over a year to write the bill because we tried to be very thoughtful about engaging stakeholders across sectors, as you mentioned, using the data, evaluating the data. So not just saying, okay, this is the problem, let's write a bill for it. Sometimes bills are written like they're in a sausage maker, right? But you really can't do that when you're talking about lives on the line, right? And so we were extremely thoughtful about doing that, and we are appreciative of our partners, some of whom are in the audience. I know March of Dimes is present. We worked with Joia, we worked with Elizabeth, we worked with partners across the states. So please make certain that if you haven't reviewed the text, HR 1897, the MOMMA Act, you'll notice that the title of our panel today is I'll Always Love My Mama. How many of you're probably looking at me like you're too young to know that song, but I know the song. I can do a little dance from the radio, from the videos, the Intruders, right, exactly, yeah. So I literally could talk to you all forever and ever, but I do want to leave time for audience questions. Let's take about 2 or 3 questions. If you have some, you can come to the stage. Feel free to share your word association if you wish. There's no pressure. Yes, please. And also, we're standing between you and your lunch. Please, no soliloquies and such like that. Get straight to your question. Thank you very much.
Noted.
Yes, let's start here.
Good afternoon. Thank you to the panel, such beautiful black women advocating for all women, and particularly women of color. I'm Dr. Renessa Anthony. I'm a physician, public health practitioner, advocate, and social entrepreneur. My question is, this conversation that we're having about oppression, genderism, and racism from a structural level, I think is really important. There's a lot of work going on in that area. And I'm posing this to this panel because of our demographics and the people in this room, is what are the efforts that are being done internally? So we know that as African American communities, our relationships are a little different. We happen to be more of a matriarchal community. How that's contributing to some of the outcomes, and specifically, what's the role of our men and our families? And I'll save my tech question for later because I can ask that of any panel, but I think this is a great panel for the role of our men and our structural community as a family.
And if you could tack onto that role of non-people of color in the space too. Who wants to answer that?
I could try to do the men. So we have struggled to figure out where the F is in MCH, right? Where fathers in MCH. I've been to a lot of federal meetings around that, local meetings. There are some fatherhood initiatives. We're also trying to redefine family. Because as we say in our mission and our vision, we want every black mother and baby to live with their families and how you define family. So we know that just saying black folks get married is not going to save us. Because when people get married, wealthy people have 2 incomes coming together, right? 2 people just coming together that won't happen. So really spending some time to think with the reproductive justice movement, also working with our brothers in the boys and men of color space. I get to go to that space quite a bit. What does it look like to bring in the idea of reproductive oppression for both groups? Because the same way that we have it, black men have it too. And then what do we do together to build out what family could look like? So there is a lot of conversation happening, but it's new, and it requires both groups to be thoughtful of the others and to pay attention to how we both enter the space. So.
Thank you, Joia. Yes, ma'am.
Fantastic panel. My name is Talithia McBride. I'm the Director of Quality at GlaxoSmithKline. As I was listening to you speak, it got very personal for me. And I began to think about my own experiences through both of my healthy pregnancies. So when I heard the word baby, I wrote healthy, right? And I'm wondering, what are your efforts to take the learnings that you're getting as you're interacting with all of these different stakeholders to feed back into training for gynecologists and medical professionals? And I raise that because of my own two traumatic experiences, being called on my job to tell me that my first baby had Down syndrome, which was not true, but I, was an older, pregnant black woman, and so I had the risk factor. And then secondly, between my two daughters, I had an ectopic pregnancy and survived it, and then had a healthy pregnancy, my second daughter, only to have the gynecologist tell me during an exam, oh, I see you had an ectopic pregnancy, and you're pregnant 6 months later, you must have Wolverine in you. So I say that to say just we talk about the near misses, but process that as a pregnant mom, and then to have to go and get prayer and to do, have my husband have to, manage that with me, so that I can still be healthy and do what I need to do for my babies. So I just wanted to hear how some of this is feeding back upstream to educate professionals on what to do and what not to do.
Thank you for sharing your story.
Yes, thank you.
We recently received some funding from the Robert Wood Johnson Foundation to work with the American College of OBGYN. My organization is the PI, the National Birth Equity Collaborative, and they are a subcontractor, which never really happens, along with Stanford University, to look at what respectful care would look like in the U.S. context. And we're interviewing black women in about 7 sites across the country to see what would a vision for a respectful care look like. It's a global term that's used, disrespectful care, but we have never really talked about that here in the U.S. And creating a metric, a patient-reported experience metric, to really hold providers accountable so they can get in trouble for saying whatever horrible things, and I appreciate you for saying that. So I just want to also know that our colleagues, my OBGYN colleagues, feel a little problematized a lot with this conversation, and there are many of you who are fighting the good fight and really working hard to work within communities, and so having Congresswoman Kelly's bill and others where we can be a part of that, we're looking at implicit bias and cultural humility and competency. It's a space where we can grow and we can lead. The OBGYNs of color really should be leading this conversation and working with our doula colleagues and our midwifery colleagues, because that's what we do naturally. So, sorry.
I'd like to add something around this. I do think, and thank you for sharing your story, we are where we are now because so many people are sharing their stories, especially women. We need all of us who are working in this space to do so. With the area of disrespect and abuse, we're also working, with an academic partner to look into this, into this issue and understand what's happening on both sides of that conversation. I think we need new tools, more tools, to figure out how to do this. I had practiced as an HIV physician, and I remember having a young African-American pregnant woman being referred to me who had been kicked out of her clinic because of behavioral issues, and at least what I got on the note, was a risk. She was a risk to the healthcare workers in the clinic. And when we did finally meet and connect, what I thought was, we need skills to figure out how to de-escalate these types of situations. As providers, we never got that training. The other thing I'd like to say around that is, when you think about a framework of trauma-induced care, you are able to now bring more people into that conversation, including the men, because we know that when women die, it has such an impact on their families, including the men folk in their families. And so you need to be able to communicate what that impact is to everybody around and have them be part of the solution. So I do think we need, all of you here, many of you are academicians, we need more tools, and we need to be working together as we are to make sure that those tools not only get to the folks who are, not only the docs, but the whole multidisciplinary care team, as well as the pipeline, so the medical students and folks, who are in training.
That's right. Mm-hmm. And Elizabeth, we're going to take your comment, and then the final question from the doctor over there. Mm-hmm. Okay.
I also want to say thank you for sharing your story and mention that, the Black Mamas Matter Alliance is working to create tools to do training. So some of our kindred partners do implicit bias training, and they work with healthcare systems to adjust their practices. Last Black Maternal Health Week, we came out with and Dr. Joi's on the advisory committee and worked closely with the CARE working group to put out a black paper called Setting the Standard for Holistic Care of and for Black Women. And that black paper outlines our vision for what high quality care for Black mamas actually looks like. It starts with listening to Black women. It's about trauma-informed care. It's about respectful care, culturally congruent care. And so I highly recommend that folks check that out. And that's something that, we're going to continue to build upon and make sure that it gets disseminated and is utilized to help providers think about how they can change their practice to be more respectful and to provide the best care to Black mamas and all their patients. The other resource that I want to mention is our policy agenda, which is advancing holistic maternal care through policy. And so what we do in here is just, again, outline our vision for how policy can support the advancement of holistic care. And the first recommendation is to ensure that black women-led organizations and Black people are included in the leadership process, right? That we have a seat at the table, that we're involved in design and implementation of program and policies that are meant to advance health equity and change Black maternal health. The second recommendation is around ending and eliminating obstetric violence, disrespectful care, mistreatment, abuse. What you experienced is abuse. I've heard a story about a woman being called an ugly monkey. We've heard about people having things done to them without their permission. This is abuse, and it's problematic, and we are going to continue to fight to end it. And the third recommendation is around ensuring that people, Black mamas have access to health insurance coverage that covers the full range of reproductive health, because that's important. A lot of people still can't access care, given, even with some of the advancements that we've made recently. And then ensuring that care is high quality, that quality is considered when not just, that you have insurance, but that you actually can access a provider that is going to be able to meet your unique needs. So I just wanted to mention this policy agenda, and hopefully you all have a chance to check it out on our website, blackmamasmatter.org.
Okay, thank you for that. I have my copy right here.
Okay, so, good.
Yeah. Okay, final question from Lauren, and then we'll just have one person answer. And for everyone else who is in line, please feel free to speak with the panelists after. Yes,
Thank you so much, Mia. So good, I think we're afternoon now. Lauren Robinson, Deputy Secretary for Health for the Commonwealth of Pennsylvania. A couple things. First, I would love to have that resource guide, the policy guide, sent to the maternal child health directors of all the states, because that kind of segues into my question, which is a combination. So as someone who is pregnant, very pregnant, I've had this conversation with so many of my peers, my friends all across disciplines, and was really surprised as a patient that no provider has brought it up with me at all. And so it's really interesting that this is in the news every day and everyone's talking about maternal mortality, but from childbirthing classes to my very diverse care team, no one has talked about increased maternal mortality among women of color at all. And so I thought that was interesting. But then as a follow-up, so HRSA convened a they had a meeting last summer to bring together all these experts to talk about maternal mortality in the United States. What are we doing? What are we doing well? Pennsylvania could not attend because they had very specific people they wanted to attend. But they just came out with a report that's available to everyone. It's posted on the HRSA website. So I was really excited that even though we couldn't attend, we could see what the proceedings of this meeting were. And in their very first key finding, they talk about disparities, primarily in rural areas, but then talked about underserved. But in that, they didn't address or give any ideas or promising practices about addressing health disparities, about the increased maternal mortality among women of color. And I was really frustrated. And as a state health official, as a black woman, as a black mama to be soon, what recommendations, like once those reports go up and that's where our states get their guidance, that's how funding is determined, how do we say there's a big piece missing here that we still need to address?
If one of you wouldn't mind taking that,
I mean,
then we'll close.
one of the things I can share, and I do think this is a role for an organization that Merck for Mothers can play, is we need to all partner around the table. Yeah. So where we see those gaps, how can that inform how we think about partnering? So one of the things that we've just done is launch what we've called our Safer Childbirth Cities initiative, which is specifically, and I see you nodding your head, which is specifically to address that gap in the community around linking community work with the work within the historical, four walls of the hospital system, and puts health equity and disparities front and center. Because what we've seen is when it's not front and center, we're actually widening that disparities gap. You've seen it happen in New York City. So it's all of us that have to keep on with the advocacy around the issue and make sure that it informs funding decisions and funding guidelines. The other point that you made about, even though we're all talking about this here, it's in the news, but when you go into the exam room with your doc, it doesn't come up. We have to figure out how to get to all women in this country around what they need to know to keep themselves healthy through pregnancy and childbirth. They need to understand what the warning signs are of these complications. One of a partnership that we have with the Nurses Association is around precisely this. But we have to also give women and docs the tools so that they can have that conversation in the exam room, with their providers. Women are saving their own lives. Unfortunately, and so we need to help them. Yeah.
Oh, yeah.
Yeah.
Yes.
So I keynoted that. The same slide that I did with racism, classism, and gender oppression started that conference. So to be clear, this is an important role for y'all to understand that you can have people to understand the work, but then what comes out of the federal agency afterwards is going to be edited. So if you don't vote, right, you will get edited versions of the exact same. I did a whole hour-long talk on racism, classism, gender oppression for HRSA that did not make the final report. So just be clear, we have to vote. Okay.
Thank you.
Channeling Congresswoman.
Wow. Yeah. Ladies and gentlemen, thank you so very much for your time and attention. Lunch, I promise, is going to be even more delicious because you were patient. I just want to say thank you to Elizabeth Dawes-Gay, who's joined us from Black Mamas Matter Alliance, to Dr. Marianne Etiebet, who's here from Merck for Mothers. Thank you so very much for your time. Dr. Joia Crear-Perry, who joins us from the National Birth Equity Collaborative. And then finally, Assistant Commissioner Lisa Asare from New Jersey. Thank you all so much. Enjoy lunch. Oh, one more thing. Congresswoman Robin Kelly is here. Hello, Congresswoman. She's my boss. Yay. Will you take a picture with us? Yeah, she has to get in a picture. Turn my mic on.